speaker is Professor Grimmer, please.
Thank you very much for inviting me to come here, and particularly to AJ for giving me so many chances to talk to you. I come from the Royal Orthopaedic Hospital in Birmingham, and I know that many of you have visited our unit, and it's very good to see so many friends here. AJ asked me to talk about my lessons I've learnt from my 40 years in orthopaedic oncology, and I will race through it. I qualified in 1976, which is probably before just about anyone here, apart from maybe Ian Dickinson. And when I was a houseman working in London, all we did was amputations, and the fatality was about 90% within a year to 18 months for bone and soft tissue sarcomas. Limb salvage had not been heard of. So the biggest change in my lifetime has been limb salvage surgery. Going overseas to visit specialists is, I believe, essential. And you might recognize some people in this photo. Does anyone recognize the guy in the middle? Stefan Bielak does. It's Rainer Kotz from Vienna. And who is the other chap? There's a handsome one on one side and another ugly one on the other side. One of them is me. Thank you. Mark Gebhardt. Well done. Mark Gebhardt from Massachusetts General Hospital, and he and I met when we visited Rainer Kotz, and we've remained very good friends hereafter. And that is very good. If you go and visit, you will meet people from other countries, and you will learn from them, and they will become lifelong friends. So what has changed in my lifetime? Clearly, surgery and adjuvant therapy has become widespread, and others will talk a lot about that. But I think that things that have changed most are centralisation of care. When I was a junior doctor, anyone would treat a tumour. Now, in the UK, we have 5 bone tumour treatment centres and 12 soft tissue sarcoma centres, and no one is treated outside them. We have multidisciplinary teams, and we have patient support networks with nurse specialists and charities supporting the patients. Clearly, there's been an information explosion. We have so much data now about outcomes. And we have technology, and Lee Jays has talked about computer navigation. And overdiagnosis of chondrosarcoma I will come to in a moment. But I want to talk mostly about things that have not changed. And I don't think we still decide sometimes what is really best for our patients. We still don't have an agreed definition of margins. We've heard already today about the high complication rate of pelvic surgery. And Stefan still can't tell us what to do with the poor responders to chemotherapy. And I don't think we diagnose our tumours early enough. So, teamwork, first of all. You should all work in an MDT. And we actually have a national MDT, which is WebEx-based, which meets once a fortnight to discuss Ewing's sarcoma and its local control, because there's only 80 cases a year in England, and each one of them is discussed with all the specialist centres. Having a circle of friends you can email with difficult cases is a really good idea, and you get so many good ideas from that. And this was a photo of our team, just to show the size of it. We have 2 pathologists, 5 surgeons, 2 radiologists, 2 oncologists, specialist nurses, and all sorts of people. Okay, decision making. This is a lesson. This chap has, his daughter is 8 years old and she has an osteosarcoma, and he wants to know what is the best treatment for her. How does he find it out? Well, this chap works for Google. He has access to all the information in the world, and his daughter lives in India. And he went to see AJ, and AJ, you'll remember this, and I think you said, give her a rotation-plasty. And he didn't like the sound of that. He didn't think his daughter would be married if she had a rotation-plasty. So he travelled the world. Look where he went. He went to Europe, he went to England, he went 3 times to America to seek the actual people who did the operations to get his opinion. And he wanted the best chances of cure, he wanted the best function, he wanted her to have equal leg lengths and the lowest risk of complications. But isn't that what we would want for everyone, for all of our patients? And these are the things that he considered. And how do you compare all these results? He was really clever, and he had difficulty, and he had to meet people face to face. He came and met me twice to talk about this, and he made me do my research, and he said, what has happened to all your 8-year-olds with a growing prosthesis? And this is what I told him. 25 growing EPRs, 15 still alive, but 5 of them got infected. 5 of them needed revising, and the function was 78%. And he didn't like the sound of that. So what did he decide? He went to Germany and had a BioExpand prosthesis put in. And it worked reasonably well, and then she fractured her femur, and it was fixed, and she did well. But we don't know how to compare all our different operations. And for the families, I think it is very confusing. Okay, margins. I've been talking about margins for years. If you look at this tumour here in red, that's the reactive zone. If you go to have your operation in Memorial Sloan Kettering, they will say an R0 or an R1 operation is satisfactory. That's the red line. If you go to Alex Gronchi in Milan, you'll get a millimetre from the tumour. In Birmingham, we try to get a wide margin, which is outside the reactive zone. And in Japan, they go for a 2-centimetre margin. So theoretically, we're all doing completely different operations. Okay, what are the outcomes? Well, if you want to know where to have your operation for a soft tissue sarcoma, in Birmingham, only 49% of our operations actually achieve a wide margin. 51% don't. And if you have an inadequate margin, that's your local recurrence rate, whereas if you have an adequate margin, it's 10%. In Japan, 60% have an adequate operation, according to their criteria. Memorial Sloan Kettering, 78%. But look at this, Alex Gronchi in Milan, 88% of his operations achieve an adequate margin. So you should all go to Milan to have your operation, right? Wrong. We're all doing exactly the same thing. We've all got 17 to 18% local recurrence rates. We're just calling our margins something completely different. We do not have a definite and clear means of describing margins that we can all agree with. Okay, what about improving outcomes for our patients with soft tissue sarcomas? Well, these are the factors which affect prognosis. We all agree on this: age, grade, size, depth, diagnosis, metastases at diagnosis. How can we, as an orthopedic oncology community, improve outcomes for our patients? Surgery doesn't feature there at all. The only way we can improve outcomes for our patients is by earlier diagnosis. And the only way we can do that is by making them smaller when they come to us. Because this is the survival rates for high-grade soft tissue sarcomas. The bigger it is, the worse the outcome. And we know in Birmingham that there's been no change in the average size of soft tissue sarcoma presenting since we first started keeping records 30 years ago, 10 centimetres. So what we do is we now, in the UK, we send a golf ball to every GP and we say, any lump bigger than a golf ball must have a diagnosis. And I just wonder if this is a message we as a group should put out around the world, that all lumps bigger than a golf ball must have a diagnosis. Finally, acetabular reconstructions. We've heard a lot already today, and we're going to hear a lot more. And we know there's all sorts of different operations you can do, and I've tried all of them. But do you know what? The trouble is they all have complications, they all have different functional results, and this was some work done by Tomo when he was visiting us in 2017. And he came to the conclusion that the less you do, the better. And the ice cream cone, which is the second along, has the lowest infection rate and probably the best function. But do you know what? As we've started giving more radiotherapy, and Lee will have talked about this already, we find that, in fact, resection arthroplasty can give surprisingly good results. Overdiagnosis of chondrosarcoma. I would just like to say, I think that chondrosarcomas have trebled in incidence since the latest WHO definition. And I think that we need to go back to saying that some of these things are benign cartilage things that can be left well alone. So finally, ladies and gentlemen, thank you for listening to me. These are the